Hi, my name is Dr. William Orr. I am Medical Director of the Geriatric Mental Health Unit here at Ridgeview Medical Center in Waconia. I'm a geriatric psychiatrist, and I've been specializing in mental health care of the elderly for over 20 years. And the purpose of this video is to provide information to family members that either have a loved one that is on our unit, or they're maybe thinking of having a loved one on our unit, because this is often the first time that families have had contact with psychiatric care, particularly in an acute setting. This generates a lot of questions naturally, and so we want to try to address those questions and provide information to families. So in all the years that I've been doing this, I typically find that families have a lot of concerns about the medications that we use, the side effects to the medications. There's a lot of information that they find online or at other resources, and as soon as they start to read about the potential side effects of the medications, this generates a lot of concern, and I think that's very appropriate that they would have those kinds of concerns. Other questions include what's going to happen to the loved one on the unit, what kind of care, what kind of treatment, and then of course, what is their loved one going to look like once the treatment is completed, and where their loved one is going to go. While those are really important questions that people have, I think the other set of questions that really come up and need to be addressed is what's involved in the diagnosis. Because really, to understand the need for the medications, to understand the treatment, you really need to understand what the diagnosis is and the sorts of behaviors that led to why their loved one is even on the unit. It's not unusual that family members don't get all of the information about why their loved one ended up on the unit. If their loved one was in a long-term care setting, for example, an assisted living, they may have some awareness as to why their loved one would need to be on a psychiatric unit, but they don't always get all of the details. So one of the things I would encourage family members to do after the loved one becomes admitted is ask questions about the behaviors, the specific behaviors that led to why their loved one is even on an acute psychiatric unit. Besides understanding the behaviors, there are a lot of questions about the diagnosis, and specifically about the diagnosis of dementia. Many patients who arrive on our unit have been going through slow, gradual changes that lead up to concerns about dementia. But there are other patients that appear to be doing really well in the community, and all of a sudden, they're going through what appear to be relatively rapid changes, confusion, delusions, hallucinations, paranoia, weepiness, that are frightening to family members because they don't understand where it came from. I focus on dementia because dementia oftentimes is behind the changes that occur in a loved one, and dementia is a very tricky diagnosis, and it's a tricky term. So let me talk about how that diagnosis is really made. First of all, let me define dementia for you. The word dementia simply means loss of brain power, which includes memory, language, decision-making, complex rule-bound decision-making that helps them navigate through the environment. But that word dementia simply is a generic term that means that people have lost the capacity very gradually to function as you would expect somebody to for their age. Now that may sound very subjective, and it is, because it's based on the clinician's impression about what a person ought to be able to do, whether they're in their 60s, 70s, 80s, or 90s. Before somebody is diagnosed with dementia, if they're starting to lose brain power, we might refer to that as simply cognitive impairment or even mild cognitive impairment. But once the impairment starts to kind of cross the threshold where a person can't reliably manage things in their environment so that they are safe, if they can't go to the grocery store and buy what they need to make their own meals, if they can't drive a car safely, and if it's not because of loss of vision or hearing impairment, but if it's because of loss of cognitive ability, that's what defines dementia. So how does that differ from Alzheimer's disease? Alzheimer's disease is a specific disease that causes dementia. Alzheimer's disease is actually a small microscopic abnormal protein that very slowly starts to form in the brain tissue, and where it does, it causes damage of the brain cells or the neurons. When it first starts out, people don't know that they have it. They don't really have any symptoms, but very, very gradually, because Alzheimer's moves slowly, brain cells become lost, so they'll start to have mild cognitive impairment, and a lot of times this will look like normal aging. So it becomes missed by family members and even by a lot of clinicians. But once it starts to cross the threshold of loss of cognitive power, where they have those problems that I mentioned earlier, that's when they're going to edge into the diagnosis of dementia.